Lower gastrointestinal bleeding. Q&A Everything a general surgery resident should know. Welcome to our channel. Today we focused on the essentials of lower gastrointestinal bleeding for general surgery residents. Today, we'll walk through the key anatomy, causes, diagnostic approaches, and management strategies in an engaging question and answer format. Pause the video when you hear the word answer to attempt answer to question. Let's begin. Anatomy and physiology question. What exactly is lower gastrointestinal bleeding? Answer. Lower GI bleeding refers to any bleeding that occurs distal to the ligament of Treitz. This includes the jejunum, ileum, colon, rectum, or anus. Question. Which arteries supply the colon? Answer. The right colon is supplied by the superior mesenteric artery via the ileocolic, right, and middle colic branches. The left colon is supplied by the inferior mesenteric artery through the left colic and sigmoid arteries. The rectum receives blood from both the IMA, superior rectal, and the internal iliac arteries, middle and inferior rectal. Question. Can you explain the significance of the colon's watershed areas? Answer. The two key watershed regions are Griffith's point at the splenic flexure and Sudek's point at the recto-sigmoid junction. Both are prone to ischemia due to poor collateral circulation. Question. Where is diverticular bleeding most likely to arise? Answer. The left colon, especially the sigmoid, is the most common site, though right-sided diverticula often result in more severe bleeding. Question. What's the difference between internal and external hemorrhoids? Answer. Internal hemorrhoids are located above the dentate line and are typically painless due to visceral innervation. External hemorrhoids are below the dentate line, are somatically innervated, and are often painful. Etiology and differential diagnosis question. What are the most frequent causes of acute lower gastrointestinal bleeding? Answer. The leading causes include diverticulosis, 40 to 50%, angiodysplasia, 20 to 30%, colitis, ischemic, infectious, or IBD, hemorrhoids or anal fissures, and both polyps and cancers. Question. What leads to diverticular bleeding? Answer. It's typically due to rupture of the vasa recta at the dome of a diverticulum, often worsened by NSAID use and aging. Question. What is angiodysplasia and where is it most common? Answer. Angiodysplasia is a degenerative arteriovenous malformation, most commonly found in the right colon. It's associated with conditions such as aortic stenosis, Hayes syndrome. Question. What are hallmark symptoms of ischemic colitis? Answer. Patients present with sudden onset bloody diarrhea, abdominal pain, and predisposing factors like atrial fibrillation, hypotension, or vasculopathy. Question. Which infectious organisms are notable causes of lower gastrointestinal bleeding? Answer. Consider C. difficile, E. coli O157H7, Salmonella, Shigella, Campylobacter, and CMV, especially in immunocompromised patients. Clinical assessment question. How do you distinguish upper GI bleeding from lower GI bleeding? Answer. Upper GI bleeding often presents as melena, with a bun-creatinine ratio over 30 and may show blood via NG lavage. Lower GI bleeding typically results in hematochezia, though massive upper GI bleeds can present similarly. Question. Which vital signs indicate hemodynamic instability? Answer. Systolic BP under 90 mmHg, heart rate over 100, orthostatic changes, or a lactate above 2 mol/L. Question. What initial laboratory tests are necessary in lower gastrointestinal bleeding? Answer. CBC, for hemoglobin and hematocrit, basic metabolic panel, bun-creatinine, coagulation profile, INR-PTT, type N crossmatch, and lactate levels. Question. Why does bun rise in upper GI bleeding? Answer. Because digested blood proteins are absorbed in the intestine, raising nitrogen levels. Question. Is the Rockall score used for lower gastrointestinal bleeding? Answer. No. The Rockall score is for upper GI bleeding and not validated in lower gastrointestinal bleeding. Diagnostic workup question. What is the first-line diagnostic test for lower gastrointestinal bleeding? Answer. Colonoscopy, performed after bowel preparation in stable patients. Question. When should CT angiography, CTA be used? Answer. In cases of active bleeding, 0.5 ml min, on stable patients, or when colonoscopy is delayed. Question. What does a tagged RBC scan provide? Answer. It detects lower bleeding rates, 0.1 to 0.5 ml min, and helps localize the bleeding site for angiography. Question. When is angiography indicated? Answer. If CT angiogram is positive and bleeding continues, angiography can also allow for embolization. Question. What limitations does colonoscopy have in this context? Answer. Poor preparation limits visualization and it may miss small bowel sources. Management question. What are the ABCs of initial lower gastrointestinal bleeding management? Answer. Airway protection if bleeding is massive, establishing 2 large bore IVs for fluid resuscitation, and transfusing if hemoglobin is under 7, or under 8 with coronary artery disease. Question. When should platelets be transfused? Answer. If the count is below 50,000 with bleeding, or below 100,000 in major bleeding cases. Question. Which medications are useful in lower gastrointestinal bleeding? Answer. Octreotide. For variceal bleeding, PPIs, if upper GI bleeding is suspected, and antibiotics for infectious colitis. Question. How is diverticular bleeding managed? Answer. 80% stop spontaneously. Colonoscopy can be used for epinephrine injection, clipping, or cautery. Angioembolization is next if bleeding continues, and surgery is reserved for refractory cases. Question. What endoscopic therapies are used for angiodysplasia? Answer. Argon plasma coagulation, bipolar cautery, or clipping. Surgical interventions question. When is surgery necessary for lower gastrointestinal bleeding? Answer. For persistent bleeding despite embolization endoscopy, or in patients with hemodynamic instability and identified sores, or ischemic colitis with gangrene or perforation. Question. What surgical approach is used for localized diverticular bleeding? Answer. Segmental colectomy, right or left hemicolectomy. Question. What is a blind subtotal colectomy? Answer. Removal of the entire colon with ileorectal anastomosis, reserved for life-threatening bleeding when the source is unidentified. Question. How do you manage ischemic colitis surgically? Answer. Resect necrotic bowel, often a left colectomy for IMA occlusion. Question. What is the mortality rate for emergent colectomy in lower gastrointestinal bleeding? Answer. Between 10 and 30%, especially if the patient is unstable or surgery is delayed. Complications and prognosis question. What is the risk of rebleeding after diverticular hemorrhage? Answer. About 25% at 4 years. Higher for right-sided disease or NSAID use. Question. What are the complications of angioembolization? Answer. Bowel ischemia, 5 to 10%, access site injury, and contrast nephropathy. Question. What's the most common cause of death in lower gastrointestinal bleeding? Answer. Multi-organ failure from shock or sepsis, not exsanguination. Question. How does lower gastrointestinal bleeding mortality compare to upper GI bleeding? Answer. Lower gastrointestinal bleeding carries lower mortality, 2 to 4%, compared to upper gastrointestinal bleed, 10%. Question. When should a second-look colonoscopy be performed? Answer. When missed lesions like angiodysplasia or neoplasms are suspected. Rare etiologies and specific conditions question. What is a doulophobous lesion in the colon? Answer. A large submucosal artery that erodes the mucosa without ulceration, causing massive bleeding. Managed by endoscopic clipping, cautery or surgery. Question. How do NSAIDs contribute to lower gastrointestinal bleeding? Answer. By impairing mucosal prostaglandins, increasing the risk of ulcers, diverticular bleeding, and angiodysplasia. Question. Is fecal occult blood testing useful in acute lower gastrointestinal bleeding? Answer. No. It's primarily for colorectal cancer screening and not for acute cases. Question. How is hemorrhoidal bleeding managed? Answer. Conservative measures include fiber, hydration, and topical analgesics. Rubber band ligation and sclerotherapy are procedural options. Surgery is for refractory cases. Question. What is the role of rubber band ligation? Answer. It is first line for internal hemorrhoids, grades 1 to 3, but may cause thrombosis or pain. Diagnostic and therapeutic tools question. What is the role of capsule endoscopy? Answer. It evaluates small bowel bleeding after negative EGD and colonoscopy. Question. When is push enteroscopy used? Answer. For examination up to 60 centimeters beyond the ligament of Treitz in the proximal small bowel. Question. When is surgical exploration needed for obscure lower gastrointestinal bleeding? Answer. As a last resort, with intraoperative enteroscopy to identify the bleeding source. Question. How is small bowel bleeding localized during surgery? Answer. Using transillumination, palpation for tumors, or methylene blue injection. Question. What is the use of intraoperative enteroscopy? Answer. Allows direct visualization of the small bowel for bleeding sources during laparotomy. Tumor-related and post-procedural bleeding. Question. How do you manage bleeding from a colonic anastomosis? Answer. Endoscopic clipping or cautery. Reoperation may be needed if severe. Question. What is the most common cause of lower gastrointestinal bleeding in young adults? Answer. Hemorrhoids or anal fissures, followed by IBD and infectious colitis. Question. What is the role of vasopressin in lower gastrointestinal bleeding? Answer. It has been used for angiodysplasia or diverticular bleeding but is associated with high complication rates. Question. How does anticoagulation affect lower gastrointestinal bleeding? Answer. Increases bleeding risk. Reversal is recommended if INR 2.5 or platelets 50,000. Question. When should anticoagulation be reversed? Answer. For life-threatening bleeding with hemodynamic instability or shock. Anorectal and fistula bleeding. Question. What is the purpose of rectal packing? Answer. To temporarily control severe rectal bleeding until definitive therapy is available. Question. How is bleeding from a polypectomy site managed? Answer. Endoscopic clipping, epinephrine injection, or electrocautery. Question. What is post-polypectomy coagulation syndrome? Answer. A transmural burn without perforation, presenting as pain and fever, managed conservatively. Question. How do you manage bleeding from a colorectal tumor? Answer. Endoscopic techniques, argon plasma coagulation, clipping, palliative radiation, or surgery if appropriate. Question. How effective is palliative radiotherapy in rectal cancer bleeding? Answer. It reduces bleeding in approximately 50 to 80% of cases. Medical and advanced therapies. Question. What are treatment options for bleeding anal fissures? Answer. Medical options include nitroglycerin ointment, nifedipine, or Botox. Surgical lateral internal sphincterotomy is considered for chronic cases. Question. What is the role of nitroglycerin ointment? Answer. It relaxes the internal sphincter to promote healing. Side effect. Headache. Question. When is lateral internal sphincterotomy indicated? Answer. For fissures persisting more than 6 weeks despite medical management. Question. How does Botox help in anal fissures? Answer. It provides temporary chemical sphincter relaxation for about 3 months. Question. How is solitary rectal ulcer syndrome managed? Answer. Fiber supplementation, biofeedback for dyssynergia, and sucralfate enemas. Surgery is rare. Oncologic and vascular causes. Question. How is bleeding from endometriosis in the colon treated? Answer. Hormonal therapy, OCPs, GnRH agonists or resection if localized. Question. How is lower gastrointestinal bleeding managed in inflammatory bowel disease patients? Answer. Medical therapy, 5-aminosalicylic acids, steroids, anti-TNF agents, and surgery for refractory bleeding or strictures. Question. When is surgery necessary in Crohn's bleeding? Answer. For massive or refractory bleeding not controlled by medical or endoscopic therapy. Question. What's the role of bevacizumab in lower gastrointestinal bleeding? Answer. It can reduce bleeding in hereditary hemorrhagic telangiectasia by inhibiting abnormal blood vessel growth. High-risk scenarios. Question. How is bleeding from an aortoenteric fistula managed? Answer. Emergent aortic stent grafting or open repair, though mortality exceeds 30 to 40% even with surgery. Question. What does TIP stand for and when is it used? Answer. Transjugular intrahepatic portosystemic shunt, used to reduce portal pressure in variceal bleeding. Question. How is lower gastrointestinal bleeding managed in cirrhotic patients? Answer. Octreotide, antibiotics for SBP prophylaxis, and tips for refractory cases. Coagulopathy and miscellaneous. Question. How should lower gastrointestinal bleeding be managed in patients with LVADs, left ventricular assisted device? Answer. Hold anticoagulation, consider octreotide or von Willebrand factor replacement, and use endoscopic therapy as needed. Question. How is colonic variceal bleeding addressed? Answer. Tips. Transjugular intrahepatic portosystemic shunt, or endoscopic glue injections. Question. What is the role of octreotide? Answer. It reduces splanchnic blood flow, beneficial in portal hypertension or variceal bleeding. Thank you for joining this comprehensive Q&A session on lower gastrointestinal bleeding management. For a deeper dive or to explore further questions, tune into our upcoming episodes and don't forget to like, share and subscribe.